Hello and welcome to a basic introduction to diabetic and hypertensive retinopathy. My name's Dia. I'm currently working in Sandwell and West Birmingham hospitals.
Hypertensive retinopathy affects up to 60% of those aged over 60 years old. The commonest cause is systemic hypertension, and this is one of the commonest diseases in the Western world. Systemic hypertension can fall under many categories. However, the commonest of those is essential hypertension, as well as renal artery stenosis.
Risk factors for essential hypertension, as we described previously, are commonly age. So increasing of age increases the risks of essential hypertension. Gender, we found that there is a significant association between men and essential hypertension as compared to women. Ethnic origin, with those of Afro-Caribbean background more at risk of developing essential hypertension as compared to white Caucasian people. And finally, societal risk factors such as industrialized urban areas as compared to agricultural and more suburban areas. And there are many theories as to the reasoning behind this. Amongst them include work pressure, as well as the overall conditions in industrial areas as compared to agricultural. Pathophysiology of hypertensive retinopathy. To simplify this for this basic introduction, there are two areas to remember. One is that elevated blood pressure can cause changes to the vasculature of the retina, and the second is the arteriolar sclerosis, so the vessel structure becomes thickened due to the raised blood pressure. Looking at the pathophysiology and focusing on arteriolar sclerosis, we can see a number of changes due to the hypertensive retinopathy. So arteriolar sclerosis is due to prolonged elevated systemic blood pressure. So although episodic raises in blood pressure can occur, this prolonged elevation will damage the arteriolar structure and cause sclerosis of these arterioles. These cause two prominent changes, the first of which is changes in the AV crossing, or the arteriovenous crossing, as indicated by the left image on the upper portion. We can see that AV nicking occurs when the artery crosses the vein, and there is almost a protrusion that is seen, a nicking that is seen on fundoscopic image, as compared to the right image where there is a normal or non-pathological AV crossing. Below, maybe a little bit difficult to see, but you can ascertain that there is a silver wiring that's occurring in arteries or arterioles in a hypertensive retina. These copper and silver wiring appearances are very prominent and common in hypertensive retina. The pathophysiology of hypertensive retinopathy is a complex paradigm to discuss. In this, we will briefly look at the common areas or the common findings in hypertensive retinopathy, as it's an introductory lecture. The common four findings to remember are exudates, cotton wool spots, flame-shaped hemorrhages, and subretinal fluid. In this image, the exudates can be noted by this portion of exudates or hard exudates commonly due to leaking of precapillary arterioles fluid into the retina. Cotton wool spots, or soft exudates as they were previously known, are seen above here and here. Again, these are a form of exudate, however these are from the nerve fiber layers. Flame-shaped hemorrhages are noted across the retina in this image. And finally, subretinal fluid, quite difficult to visualize in this image. There are multiple complications of hypertensive retinopathy to be aware of, the commonest of which include central retinal artery occlusions, central retinal vein occlusions, or CRAO and CRVO, and their respective branch retinal occlusions. Other further complications include progressions of diabetic retinopathy, which is a further condition which we will discuss. Macroaneurysms can commonly be seen, as well as non-arteritic ischemic optic neuropathy, a condition which will require further research, as it is not within the scope of this lecture. Finally, oculomotor palsies such as cranial nerve 3, 4 and 6 with their various presentations can also be seen. Investigations and treatment. To simplify this, the commonest things that we can do as general practitioners or foundation year doctors is initially to control the blood pressure and to monitor and assess vascular risks that we've discussed previously. So further risk factors that were not previously discussed, such as the modifiable risk factors, such as smoking, alcohol, diabetes. These are all these all can combine in a combination to affect hypertensive retinopathy, and as a result will require treatment, assessment and monitoring, specifically to reduce the risk of worsening of hypertensive retinopathy. Accelerated or malignant hypertension is specifically when there is a severe acute rise in blood pressure in a patient, and the outcome that can be seen can affect multiple organs. There are 3 or 4 organs that are commonly affected by accelerated or malignant hypertension. Strokes of the first risk from accelerated malignant hypertension. Secondly is nephropathies in the kidney, and the third commonest is a hypertensive retinopathy. There is a classification which we can mention whilst discussing malignant hypertension, i.e. a severe acute rise in blood pressure where the systolic is above 220 or the diastolic is above 120, with findings of papilledema or fundal hemorrhages and exudate. So the first grade in the Shea classification is grade 1, where there is arterial narrowing or AV. AV nipping is another finding in the arteriolar narrowing. Grade 2 is where we see larger retinal arteries narrowing. Grade 3 involve retinal hemorrhages, exudates and cotton wool spots, as well as retinal edema. And finally, papilledema, as can be seen in this image as well as this image, alongside grade 3 findings of cotton wool spots, which are in this image, as well as exudates seen in this image. Clinical features of accelerated hypertension. As mentioned, these can affect a number of organs, malignant hypertension and accelerated hypertension. End organ damage, such as those that affect the brain, such as stroke and encephalopathy, renal failure from those nephropathies caused, as well as cardiac failure and MI. From an ophthalmic point of view, there are a number of effects which we are not able to discuss in detail at this point in time. However, various diplopia or double vision, scotoma, an arced loss of vision, decreased visual acuity is common. Retinopathy, as discussed previously with their findings, and various choroidopathies and optic neuropathies, which can be seen, i.e. with papilledema or infarcts in the retina. The management of malignant hypertension requires urgent admission and cautious lowering of blood pressure, commonly with calcium channel blockers. Moving on to diabetes and the manifestations of diabetes. So this is a disorder of vasculature secondary to poor glycemic control. There are various findings from complications of diabetes, including cataract formation of a specific specific type, as well as labile glycemia, which can affect the vision or visual acuity by causing transient blurring of vision. Retinopathy is a third common manifestation of diabetes, which we will discuss in detail, as well as rubeosis affecting the iris. Diabetic retinopathy can present with sudden, painless loss of vision. Although labeled sudden, this visual loss can also take place over a range of time or period of time that is longer than what we would normally consider as sudden. Its pathogenesis includes microangiopathy in capillaries, so occlusions leading to leakage, and there are three main stages shown in the images commonly, which are proliferative, pre-proliferative, and background. The reason for diabetic retinopathy occurring is we have VEGF, or vascular endothelial growth factor, released by ischemic retina. So when the ischemic retina releases this compound, it increases vascular permeability and more leakage, as well as causing further edema. This further edema and permeability leads to a further blood vessel recruitment and increase in production called angiogenesis, and these new blood vessels that are formed are much more friable and weak, and they're liable to bleeding. A patient who's come in with diabetic retinopathy will have a history of decreased or fluctuating vision, floaters, defects in the visual field. They are commonly known to the ophthalmic team and opticians, as they are, over a period of time, due to poor control, increasing their chances of having more proliferative diabetic retinopathy. The management of diabetic retinopathy we will come on to. However, it is likely that management of blood pressure and HbA1c are the prominent factors in the initial background and pre-proliferative stages. On examination, slit lamp fundoscopy and intraocular pressure measurements are important to rule out subsequent glaucoma. Rubeosis or new vessels of the iris are significant signs of diabetes and should also be checked due to the risk of glaucoma. Neovascularization of the disc, as well as changes in the macula, such as microaneurysms, hard exudates, and cotton wool spots, are important. Further diagnostic checks or investigations include FA, or fluorescein angiography, which assesses the degree of ischemia and neovascularization. Ocular coherence tomography can also be used to see the significance of the edema around the macula. Stages of diabetic retinopathy can be classified into 3 or 4 stages, the commonest of which are the below. Background diabetic retinopathy includes microaneurysms, exudates, and hemorrhages. Microaneurysms, exudates, and hemorrhages have a management plan of watching and waiting. So approximately 6 months to 1 year appointments with the optometrists are required, as well as management of the background HbA1c levels in diabetic patients and subsequent blood pressure management in those with hypertensive retinopathy alongside hypertension, as well as hypertensive retinopathy alongside the diabetic retinopathy. Pre-proliferative stages of diabetic retinopathy are where we start to see venous beading and looping of vessels within the retina. These require more frequent appointments and so can be considered to be 3 to 6 monthly appointments with an ophthalmologist. Finally, proliferative and end stage. Proliferative is referring to the production of new vasculature, i.e. angiogenesis. This can affect the disc as well as the retina, and as mentioned previously, the effects of this neovascularization are increased vitreous hemorrhages, and therefore these can present as sudden painless losses of vision when vessels bleed and form a vitreous hemorrhage. When these happen, there are two major management mechanisms, the first of which is urgent pan-retinal laser photocoagulation, and the second is with anti-VEGF injections to ensure that the ischemic areas do not neovascularize as frequently or as largely. Finally, those with end-stage diabetic retinopathy produce large amounts of neovascularization, which then bleeds, fibroses, and can cause retinal detachments due to the significance of the vitreous hemorrhages, fibrosis. And these require specific subspecialized vitreoretinal surgery by ophthalmic surgeons. As mentioned previously, treatment of diabetic retinopathy includes stringent control of the diabetes, stringent control of the high blood pressure, and stringent control of hyperlipidemia, as well as stopping smoking. These are controlling the modifiable risk factors. Additional injections of anti-VEGF and pan-retinal photocoagulation with laser can be used to prevent further neovascularization in cases of retinal edema or neovascularization of the retina. Surgery is mainly aimed at removing that fibrosed scar tissue and also managing the retinal detachments of diabetic retinopathy.